Awesome. Well, good afternoon, everyone, and welcome to SCAGO Summit 2023. My name is Dr. Dana Powell. I am a medical strategist who works in the healthcare space, as well as I'm on the board of directors for SCAGO. So I'll be moderating today's Psychosocial Track 2 session on investigating the transitionary process from pediatric to adult care and improving transitional readiness for youth with sickle cell disease. Just wanted to do a few housekeeping things, but of course, if you are members of your network would like to refer back to any of this information that is shared in today's session, a recording of this will be posted on our website. So www.sicklecellanemia.ca, and so you can return back to that for your own viewing convenience. In this session, we're super excited today. We'll be hearing from 5 panelist guests who I will introduce shortly. And, of course, I'll be giving quick introductions on them. But if you want to know more about them, go to our speakers page on SCAGO website to get more of bio information on our amazing speakers today. So just before we get started, just a few housekeeping rules just to ensure that we can have a nice, smooth, efficient session today. So we just ask that you save all of your questions, thoughts, or concerns until the latter part of our session, where our guest speakers will be able to answer each of these questions individually. We ask that you just respect the learning being done in this space. So you're abiding by these few housekeeping rules, such as just making sure your mics have been disabled for the duration of this webinar. If you would like to ask a question, simply go into the Q&A chat function or by raising your hand at the end when we have that session. We'll try our best to get through all of the questions during today's session, but if we're unable to, we'll try to have follow-ups accordingly. You can also access our translation captioning. So that's been provided. So pretty much just clicking show caption at the bottom of your Zoom screen. You can check out that feature now, enable translation checkbox, and then choose a language of your choice, because we want to make sure that today you're able to follow and understand what our speakers are sharing with us. Please note today's session is being recorded, and so you can access this also at a later time. Regarding our Q&A period, questions, as I mentioned, please remember you can post it in the Q&A feature or the live chat, and we will make an effort to answer all of these appropriate questions in the order in which they come in. Also, you can feel free to raise your hand to notify us if you need to be unmuted to orate a question. We're just asking for everyone's mutual respect in terms of in your language in this chat. We want to keep appropriate images post and no profanities, etc. No post of other material unrelated to today's discussion and sessions, very important. As well as, let's keep our comments and discussions on topic as much as possible. And we do reserve the right to pause any session or to remove any participants who are not abiding by these rules. So thank you so much for your understanding, so that we can have a very productive and positive participation. So we're super excited to get our speakers going. And with that, I'm going to introduce our first speaker of the day. And I hope you're as excited as I am to hear from Dr. Kofi Anie. So he is the Psychology Service Lead for Children and Adults with Sickle Cell Disease and Thalassemia at London Northwest University Healthcare NHS Trust, and the Deputy Clinical Director of the West London Hemoglobinopathies Coordinating Center. So if you want to know more about Dr. Kofi Anie, as I mentioned, go on the speaker bio. But without further ado, we're going to let Dr. Kofi Anie take us away, and we're super excited to have you be on this platform, Dr. Kofi. Thank you.
Thank you so much for your kind invitation. So I'm going to try and talk you through self-management tools for sickle cell disease, and with particular emphasis on apps as well as digital platforms. So just as a quick reminder, obviously being a psychologist, I thought it would be great to start by looking at, some of the things that people with sickle cell do talk about. And when I take, some of the frustrations or what are some of the issues that they worry about, in terms of psychological distress, as you can see, covering a whole range of things, so people talk about being stressed, being helpless, depressed, of course, nervousness, anxious, but importantly, talking about things like I feel misunderstood. And this comes out a lot with frustrations when they present in, let's say, the ED at the hospital. Some worry about, doing exercise because obviously they have problems with fatigue, for example. Social stigma is a big thing as well. But ultimately, as you can see, unfortunately, some people worry about dying. And that is simply because, sometimes with the unpredictability of crisis and so on. But importantly, they also talk about, professional support. And I think regardless of whether you are coming in as a healthcare professional with a medical background or medical training like doctors, nurses, psychologists, I think professional support is quite important, and working towards that within a multidisciplinary context is also quite important. But looking at the overall psychological burden, this is taken from a publication about 2 years ago, for which I, together with other colleagues, contributed to this chapter, which is psychosocial burden in sickle cell disease. So breaking it down, starting, for example, looking at negative thoughts and low self-efficacy, as well as self-doubt. This is on the one hand. Perceived stress, as you can see from the earlier slide that I showed as well. Sometimes people are overwhelmed with helplessness and feeling that life is out of control. Depression, quite important in terms of their mood, and also anxiety on the other hand. I mean, those are two fundamental psychological or emotional well-being issues that a majority of sickle cell patients would feel at one point in time or another. So depression, worry, irritability is quite important. But also it appears from a physiological point of view that, and we tend to see that, when patients have sort of pain, for example, you get muscle tension. But also it's been shown that, adrenaline and cortisol levels also go up, and sleep is disturbed. And then obviously pain, as we know, probably the hallmark of sickle cell disease. It's uncontrolled pain with hospitalization and an increased use of medications, for example, opioids. But the other area that we probably haven't looked at a lot in the past, but is becoming more prominent, is what we call the social determinants of health. So these are social issues that really affect people with sickle cell disease. For example, job loss. A lot of the young people that I see, we're talking about transition of teenagers, for example, when they get to an age where they want to start employment, sometimes, unfortunately, they get interruptions with their, with their health, with painful crisis, for example, in and out of hospital, frequent admissions, and they can't easily retain a job, and that is quite sad in most cases. We also see that, sometimes, unfortunately, there might be family conflict for various reasons. And that is also one of the important external stresses. We have bills, that is, for example, living costs in recent times has risen quite considerably. I'm just looking at people's mortgages, for example, as well as those that are renting, everything just getting out of hand. We have particularly energy sort of crisis in a way, and in recent years with the wars and whatever, and the global prices of energy going up, household bills, for example, electricity and gas bills have really gone, sort of through the roof, and some exponential kind of growth. The other thing that is also quite interesting is childcare. A lot of people affected with sickle cell disease might have childcare problems, and this is affecting, for example, the ability to have employment. But unfortunately, in some cases, we've actually seen that even when, somebody has to come to hospital, they may not necessarily have the childcare support in place. And in our case, for example, I've seen in recent months, a couple of, young people who have young children have come in without childcare support. They've come into the ED with a child, and we've had to find, ways in supporting them in that sort of emergency situation. And then also there might be unexpected health complications, because as we know, you might be, sort of vulnerable to other health problems, regardless of the fact that you might have sickle cell disease. So if you combine all this, we try to encapsulate all these issues into what we would refer to as the psychological burden, but I think really it is the psychosocial burden. And then moving on from there, when we talk about psychological interventions, basically we have to look at, what we do in terms of assessing the individual as well as the family in the case that is relevant. And we have what you call patient-reported outcome measures, as well as we have neurocognitive assessments that we also do. And then secondly, in terms of the therapies, I just break it down into three main areas, even though they are quite a lot under each. So you have psychoeducational, whereby it's more about patient education, as well as, psychological sort of information that can be used to improve their well-being and outcomes. We have behavioral interventions. These are quite common. For example, you have cognitive behavioral therapy and other therapies that are related. And in recent times, I think supported self-management has become one of the key areas whereby you can utilize, various tools, for which I'm going to give examples of today, but supported in the sense that you don't just leave the individuals or the families to manage on their own, but you try and support them, even though they are using these self-management tools. And so as a combination, you kind of rotate between these two areas. So doing assessments to offer the right therapy, and then also reassessing to make sure that the therapies that you've offered or the interventions that you've offered are appropriate and continuous. Moving on from there, I just wanted to share quickly some of the psychological assessments that are available by looking at the various domains. So you can see I've highlighted some key ones, from pain to anxiety, depression, quality of life in general, and fatigue, which is something that a lot of patients have been reporting in recent times. And then breaking those down into pediatric and adult measures, you have what you call generic outcome measures. And these generic ones are basically not specific to sickle cell disease, but has been used and can be used, measuring things like pain, looking at anxiety. You have, for example, what you call the Beck youth inventories for the children. In depression, you have child depression inventory, and also the Beck youth inventories do cover both anxiety and depression. For quality of life, if you look in the literature, you see quite a whole range. I've just highlighted a few here. You have the AQ5D, the youth version, which we do quite use quite commonly here in the UK, for example. I use that quite a lot. And then you have the child health questionnaire, and also you have the pediatric promise, which is a generic measure that was developed some time ago and has been utilized quite effectively. And within that, there is a fatigue measure as well. And then with the neurocognitive assessments, the common ones are basically the Wechsler scales, but there are loads and loads of them. I could hardly list them over here, but these are just to highlight some examples. And when we go to the Sickle specific, there's been a lot of work done with the PID score, SCD, which covers things like pain, anxiety, depression, all these key domains, quality of life. And within that as well, there's a fatigue module, which is very appropriate for sort of pediatric assessments in sickle cell disease. On the adult side, again, you have generic adult sort of measures that you can use. The adult promise is available. You have things like the hospital anxiety and depression scale. You have the generalized anxiety disorder 7, Beck anxiety inventory. Again, you have HATs for depression. You have the PHQ-9 also available, measures depression, which is quite appropriate and also quite short and been used in a lot of studies to measure outcomes. And then the Beck depression inventory has been around for a very long time. You have the AQ5D, you have the SF36, you have the adult promise, also covering, and again, Wechsler scales just as one example. As I said before, there are many. And again, the Ask Me, which is the adults kind of validated sickle cell assessment measure, widely used, covering all these domains. And these are just some examples of assessments that we tend to use for measuring, and also evaluating psychological therapies. Now, when we come to digital health, so what exactly is it? So according to the WHO, the definition, digital health simply means knowledge and practice associated with the development and use of digital technologies to improve health. And it's kind of broken down e-health, which is the broad term that is utilized quite a bit. It's the effective use of information and communication for health-related purposes. But within that, you also have m-health, which is basically provision of information and services through mobile technologies or mobile health technologies. We also use telemedicine quite a bit, which is basically the remote practice of medical interventions or examinations. This term can be modified to telemedicine, from telemedicine to telehealth, so that it incorporates other interventions that are not necessarily medical. So when I use a telehealth platform, for example, to sort of work with patients, which is just a virtual thing, like a video platform or something, then I'm practicing telehealth, not necessarily telemedicine. And again, another area of digital health that is growing exponentially, computing techniques. I don't know whether some of you might have picked up that there was an an artificial intelligence big summit in the UK running this week with people like Elon Musk and others that have attended. So AI is becoming one of those areas whereby I think would have a lot of input into how we manage people with sickle cell disease and obviously other health problems in the future. And it's already taking hold in some of the work that is being done. And also what you call natural language processing, which assists in extracting and analyzing big health data. For example, genomics, medical imaging, health records, medical devices, apps, and wearables. And these are all becoming, quite important. So when we look at digital health within the context of the kind of tools that we're going to be using for self-management, specifically for people with sickle cell disease, we have a lot of areas that we can cover. So I'm just going to show examples of some of the apps that are available, as well as digital platform or whatever. So starting with patient education, for example, this is one that we developed ourselves within my hospital, and we worked with children and teenagers on this. So usually I do patient educational kind of sessions in groups with the children as part of initial interventions that we offer. And it came to a point whereby we just wanted to find out if we could develop something that could sort of support the patient educational stuff that we do. And so we worked with the children and the teenagers. They came out with the name Sickle Buddy, and eventually we developed this app. It's a bit old now. We actually need to update it, but it's still available on the App Store, I believe. And it's broken into sort of three key areas. The facts, this is basic information about sickle cell. And my health just covers all these areas of, healthy things, healthy tips, and then healthy sort of ideas. The healthy tips are actually, things that they wanted to be covered, but also we thought was appropriate. For example, having a balanced diet, drinking lots of fluids, having rest, keeping warm, participating in activities within reason, without overexertion, but not being, sort of feeling that they can't do anything, and the sort of medicines that they need to take. And then the healthy ideas is more based on a psychological kind of, so that's where the psycho bit of the educational comes in, and things like relaxation, positivity, networking with friends, keeping diaries, having fun, and also trying to de-stress as well. And so if you look at, go into just a little bit more detail, it's just about, how they can use positivity. For example, if you feel pain, think of a positive word such as calm and relax. Think about a nice holiday where you had something and made a smile and what made you happy. So this is some kind of imagery. So kind of based on some of the psychological interventions that we offer. But the key thing is that this is just a typical example, and there are so many apps out there that offer similar things as well as other things as well. The second area that I wanted to look at was a type of app that I would refer to as a comprehensive self-help kind of app. So it's a comprehensive self-management. So one example is called My Sickle Care, and it covers both physical and mental aspects in terms of monitoring symptoms in a kind of a diary. There are medication alerts, because as we know, adherence to treatment or adherence to medications can sometimes be a problem. So that helps in reminding, individuals. Again, there's sickle cell education, and as you can see, as I said, it just covers some of the basics about sickle cell disease. So it says, what is sickle cell disease? Goes through all that, differences between a normal red blood cell and a sickle cell, and it just gives that educational information.
Sorry, Dr. Interrupt. We just want to ask you if you can wrap up in the next minute, as we just gone a bit over time. Sorry to interrupt. Thanks.
Okay, so and looking at that, it sort of covers comprehensively some of the areas. A second app, which does more or less the same thing, again, carries sickle cell education, potential triggers, management techniques, and so on. And as you can see, it's quite a comprehensive app as well. Then the next example is one about communities and trying to connect people. In this case, connecting peers to build up, a network and to learn from others, to share experiences and track, again, incorporating some daily symptoms and pain crisis as well. This is our own digital platform that we are working with this company, Sinus Health, and it's basically combining all the daily information that you can track in a wearable through an app, and then combining it with, healthcare records. So if you see, we started with patient focus groups and questionnaires to design this. And then, you get the hospital and pharmacy data, you get the GP, the family physician records, and it combines, sickle cell information through the wearable and goes onto a platform, and then trying to do some predictive analytics with it. Just to highlight a couple of feasibility or proposed studies. So just to one study which used an app called SMART for individuals with sickle cell, using the app between 1 to 6 months and recording daily pain twice a day, twice daily pain, in terms of the intensity and location and the medication. And the outcome was basically to see whether, you could support the use of mHealth for daily pain and symptoms, and that is pretty obvious. The second one, which is a proposed study that I believe is currently in trial, is about a random controlled trial for about 8 weeks, using an mHealth app for self-management, relaxation and distraction, and support versus support only. And the outcome that they're expecting to evaluate is stress, pain intensity, and the use of opioids. So in summary, digital self-management tools can empower people with sickle cell disease to better monitor their health and manage their symptoms and improve their overall quality of life. But however, it is important for individuals to use the most appropriate tools in collaboration with their healthcare professionals, so that they can effectively self-manage their condition. Thank you.
Amazing. Thank you, Dr. Kofi Anie, for that excellent presentation. We will, as I mentioned, save our questions for the Q&A session at the end so we can address it to Dr. Kofi Anie. Next up, so we have Geil Astorga, and you've completed your Master's of Health Science and Translational Research at Optometry, Faculty of Medicine at University of Toronto. Her capstone project focused on designing an intervention with patients to support youth with sickle cell disease as they transition from pediatric to adult healthcare. And my understanding is that you're speaking along with your peers, which Peola, Ellis also recent graduate from the University of Toronto, where you studied translational research in interdisciplinary health sciences under the same faculty, Optometry, Faculty of Medicine. Fairuz, hopefully I said your name correct this time, Fairuz Karim. She's also a recent graduate of the Translational Research Program at the University of Toronto. And she's completed a master's in health science in translational research. And we have Jaspreet Randhawa. And she are also a healthcare innovator and educator in the field of pediatrics, orthopedics, cardiology, and urinary health. You've completed your master's in science in medical education at Harvard University. Harvard Medical School, right? So I left out that detail. Awesome. So we are going to pass it over to these speakers so that they can present to us. And as I mentioned, let's save our questions for them at the end. Thank you. Over to you, ladies.
So the single most unused person in healthcare is the patient. Hello, everyone. We are graduates of the Translational Research Program at the University of Toronto. While doing our master's, we had the opportunity to listen and hear Serena Thompson's experience as a person living with sickle cell disease, or SCD. Her experiences motivated us to investigate how we can better support people living with SCD, specifically youth, as they transition from pediatric to adult care. Our capstone team has been working together since September 2021 and recently defended our research this August. We are known as Team SMART, or short for Sickle Cell Disease Management, Advocacy, and Resources for Transitioning Youth. We are so excited to share our work with you today. So here is our team, and today myself, Geil, Peola, Fairuz, and Jaspreet are presenting. We are also thankful for the support of our advisory committee, Dr. Richard Fody, Dr. Edita Marcon, Serena Thompson, James Bradley, and Dr. Jim Slaughter.
So here's an overview of what we'll be covering today. And as we gather virtually today in Canada on Turtle Island, we invite you all to acknowledge and give thanks to the traditional lands that you are situated on. At the University of Toronto, which we are all, us as students, are coming from, that is the land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. So we'd first like to start off with a little bit of background on sickle cell disease, or SCD for short, which we all know is a genetic condition that's characterized by sickle-shaped red blood cells that are prone to clumping together, blocking oxygen flow, and causing acute pain crises. And some of these crises can be managed at home, but severe ones need emergency department or ED visits, where pain medication must be administered. So in Canada, there are about 6,500 cases, with the majority in Ontario, primarily in Toronto and Ottawa, with the average age being 24 years old. And while there is limited racial data available in Canada, stats from the US show prevalence to be higher amongst Black individuals, with 93.4% of diagnoses compared to 1.8% of diagnoses amongst white individuals. So we'd like to focus on the shift from pediatric to adult care. Now, this shift is a critical phase, as a rise in mortality has been found between 20 to 24 years old, which coincides with the time of transfer into the adult care system. And studies have revealed that doubt from healthcare providers, or HCPs for short, contributes to this issue, as patients have reported skepticism from providers regarding pain treatment. And this doubt often will stop youth who have already transitioned into the adult healthcare system from seeking care, where a study found that 88% of youth 21 to 25 years old will delay seeking care in the ED until their pain is at an 8.7 on a 10 scale. Evidence also suggests racial bias in pain perception and treatment, where a study found that within the ED, children with SCD, of whom 88% were African American, faced longer delays in receiving pain medication compared to children with long bone fractures, among whom 15% were African American, despite both necessitating high priority triage. So other common challenges that are experienced by youth during this healthcare transition include the lack of familiarity and awareness of SCD among adult care providers, difficulties in transferring care responsibilities from caregivers to youth, and differences in the culture of care between the pediatric and adult EDs, in which the adult EDs seem very isolating, non-compassionate, and non-communicative. So to better understand the state of transition programs in Ontario and to understand the needs of youth, we conducted an environmental scan consisting of informal community interviews with patients and healthcare providers, and a literature review of transition programs for sickle cell disease, as well as other chronic conditions like diabetes. So from this, one recurring theme was found, which was the need for support from healthcare providers throughout transition, including preemptive support to ensure that youth feel transition ready.
Thank you, Fairuz. Now we'll move on to our research purpose. Our project identified that youth with sickle cell disease receiving care at pediatric centers need ongoing support as they transition to adult centers. Our research question investigated how transition readiness can be increased to improve outcomes for youth with sickle cell disease. And our capstone's goal was to use a participatory design approach to create a low-fidelity prototype to enhance the transition readiness of youth with sickle cell disease during this transitionary process. So what did we do? Our team is creating an educational module for healthcare professionals focused on the transition of youth with sickle cell disease from pediatric to adult care in partnership with SCAGO. So how did we get there? For our methods overview, we used a participatory design approach through co-design and community consulted design practices. In total, there were 6 sessions as shown in the diagram. This is a visual of our process flow. The yellow represents our 3 participatory design sessions, whereas the black represents our 3 internal team sessions. Our team emailed multiple organizations, reached out on social media, and contacted people in our network for referrals. Participants were finally recruited through referrals from SCAGO, sickle cell disease advocate Serena Thompson, and transition navigator James Bradley. Lastly, it's important to note that a thematic analysis of design session 1 was conducted to gain insight into the experiences, viewpoints, and current state of the transitionary process. Now to go into a bit more detail on our participatory design process. These sessions were mapped out based on a human-centered design scaffolding process. Session 1 helped verify our understanding to define and frame the context. Session 2 helped develop a criterion for design requirements. Session 3 helped us ideate concepts based on the design requirements. And using session 4, we were able to validate the findings and translate them into tangible concepts. In session 5, we focused on testing and iterating the prototype design. And lastly, in session 6, we developed a low-fidelity prototype. Now moving on to the results and the discussion. For our first design session, we had a total of 6 participants, 2 of which had sickle cell disease, 3 had lived experience as well as a healthcare background, and 1 was a nurse practitioner. To examine the current and desired state of transition goals, we developed activities for the 3 phases. Firstly, to look at where are we now. Secondly, to see where do we want to be. And thirdly, how will we get there? We started off with general brainstorming and then converged and did other activities, such as persona building, the 5 whys, and the how might we's. We brainstormed with the entire group and conducted activities in Zoom breakout rooms. For further detail on one of the activities, we want to briefly show the results of the persona building as they were used throughout the design process. Personas were an activity to first understand the transition journey further. Secondly, think about them during our team sessions when selecting the design requirements. And thirdly, when testing the intervention to know which is the most feasible. Participants created the following 3 personas: George, Anna, and Chris. So first is George. He's a 19-year-old Black male living at home. He wants to go to school and move out, but can't afford to due to the high costs of living. Next, we have Anna, a 21-year-old Black female who's in the upper middle class. She's living away from home on campus and facing challenges with independence. Lastly, we have Chris, an 18-year-old African Canadian male living at home with siblings who just graduated from high school. He wants to be a healthcare worker, but struggles with self-confidence due to having sickle cell disease, while his siblings do not.
Thank you, Jas. So for design session 1, as mentioned earlier, we completed a thematic analysis, and this was done for 2 reasons. The first was to verify the current state of transition, and the second was to verify our findings with the environmental scan findings. So the thematic analysis framework was developed using Braun and Clark's framework, and an analysis of the second and third design sessions were not done, as those sessions focused on collaborative ideation. So this analysis was done in 3 steps. First, the Zoom transcripts were de-identified, exported, and then uploaded into a thematic analysis software called Quarkus. Secondly, we individually coded a small sample of the data and created initial codes, and then met to create a shared codebook. Then we coded the remaining data using the codebook. And finally, we met at the end to group codes into themes. So on the screen here, we've shared how each subtheme and their codes were grouped together in Quarkus. And from this analysis, we had 1 main theme of barriers to transition with 4 subthemes on 1, lack of education and awareness, 2, limitations in healthcare delivery, 3, navigating multiple transitions, and 4, racial bias in healthcare. So to put it all together, we generated a word cloud where you can see that the most prevalent word was hospital, indicating the central role that it plays in healthcare transition. And another important word being person, and also education, emphasizing the importance of person-centered care and the need for greater sickle cell disease awareness and education. So to share some of what participants were saying for each subtheme, in lack of education and awareness, a participant noted healthcare providers' unawareness of sickle cell disease in the emergency department, leading to symptom dismissal and inadequate care. And in navigating multiple transitions, it was explained that youth simultaneously handle healthcare and life challenges at the same time, like school and work. And in healthcare delivery limitations, participants explained that while protocols exist in the ED, there is limited accountability and practice to actually use the protocols. And finally, in discussing racial bias in healthcare, participants described persistent myths about pain tolerance and drug seeking, contributing to racial bias towards Black individuals with sickle cell disease in pain treatment.
So next here, the participants identified barriers to transition to help us narrow our capstone focus. They selected 2 issues to tackle: self-management of SCD and providing holistic healthcare. Participants then identified the root cause, which is the lack of HCP training and awareness specific to transitioning youth with SCD among adult care providers. For example, in internal medicine and the ED, as well as other areas of the adult healthcare system where encounters may occur. And to tackle the root cause, participants of Design Session 1 shared potential interventions. First are mini cards with personal information of patients and protocol guides. Second are workshops tailored for target audiences to learn about SCD. Third is support from a transition navigator for youth. Next, an online module for healthcare providers to learn about SCD. And lastly, peer support and mentorship. So the purpose of our first team session was to develop criteria for design requirements to set the design direction moving forward. We then evaluated the interventions co-developed with participants using a feasibility and desirability matrix. We want to know if they meet the needs of youth with SCD while also considering the team's resource and expertise. The most feasible and desirable interventions were the online module, lunch and learns, and mini cards, as you can see on the screen. So now into the results of our design session 2, where we had a total of 7 participants. Participants discussed for an hour and decided to move forward with 2 interventions, workshops, and creating an online module. For the workshops, they could be for healthcare providers in internal medicine, where individuals with SCD can lead the sessions and then educate them about the disease. And next here is the online module for healthcare providers in the emergency department. The focus would be on empathetic communication with patients and being accountable for the care they provide. So then, based on conversations with participants and the internal team, we chose the online module as the most appropriate intervention to move forward with. We think this would help improve the care that patients with SCD receive through healthcare provider education. This intervention highlighted the importance of empathy, compassion, and accountability in continuing education. Studies also show that empathetic care that providers provide who understand their patient report better patient outcomes, which is what is needed to address patient-centered needs. So from this, we moved into team session 2, where the purpose was to validate the findings from previous design sessions to translate into tangible concepts. And in the next session, we analyzed the insights around the personas and participant experiences to start developing a low-fidelity module framework.
Before creating the plan, we considered findings from participants and the literature. Participants shared that there is disjointed care once a transition occurs from pediatric to adult healthcare. This means that their care coordination is no longer centralized to a team of healthcare providers. Instead, they are expected to manage their healthcare with limited support. Participants emphasized in their experiences that many adult healthcare providers have limited knowledge of sickle cell disease, thus affecting the quality of care they receive. These findings also reflect the barriers identified in the literature, including the lack of training and experience of adult care providers in sickle cell disease, stigma towards sickle cell disease, and the perception of drug-seeking behavior when seeking treatment. These barriers not only widen the health inequity gap within racialized populations, but also decreases the quality of healthcare and further reinforces the aspect of self-dependency even during life-threatening health crises. Recently, Ontario Health also administered the quality standard of care for sickle cell disease, emphasizing the importance of care that is free from racism and anti-Black racism, comprehensive healthcare plans, treating and managing chronic pain, and viewing treatment holistically. Importantly, these standards are also reflective of the literature and what participants shared. However, despite the administration of this document, it does not ensure standardized healthcare delivery. So while considering the literature, health quality standards, and the voices of participants, the 5 components of the plan for the framework were mapped out. And they were: number 1, presenting the disjointed care in sickle cell disease, transition, and gaps in quality of care, together with the need for healthcare provider education. Number 2, tackling the emergency department, sharing up-to-date guidelines, protocols, and initiation of triage. Number 3, discussing psychosocial factors associated with sickle cell disease, such as relationships, education, work, lifestyle, finances, and families or caregivers. Then moving on to number 4, discussing compassionate and empathetic communication. Healthcare providers need to communicate in understandable language, be aware of anti-Black racism, and be mindful when working with youth, since this is an impressionable age group. And number 5, discussing youth engagement, where we would introduce strategies for patient and family-centered care, and how can patients have an active role in care planning and share different types of resources. Now moving on to design session 3, we compiled our findings and planned for the online module. We then presented this plan to the participants and stakeholders to get their feedback for iteration. After presenting our plan for the low fidelity module framework, the participants found all of the topics to be important for transitioning youth, but asked us to be cautious about the emergency department section, as it may already be a part of other existing learning modules. Participants also asked how we will disseminate the module to care providers with patients who have sickle cell disease. So after integrating the feedback from the last design session, the 5 key components of the plan were translated into section headings of a low-fidelity module framework, as seen here. So this includes, number 1, unique challenges during transition. Number 2, effective healthcare provider-patient communication and care coordination. Number 3, comprehensive care plans for transition. Number 4, case studies and practical applications. And number 5, ethical and cultural considerations. In the framework, we've also included an introduction and conclusion while integrating resources, tools, assessments, and evaluations throughout the module framework, rather than providing them with separate sections. Now, those section headings were then iterated to create a comprehensive version of the module framework with topics for each section heading to delve deeper into the information that would be necessary to cover. For the sake of time.
Sorry to interrupt you. Just wanted to give you a reminder, 1 minute to tie up stuff if possible. Thanks.
Thank you. So for the sake of time, we won't go through each topic as it is being further developed and expanded beyond this snapshot here. So we also created learning objectives to ensure that healthcare providers feel equipped and prepared to use the knowledge that they have learned to then apply to their practice when caring for transitioning sickle cell disease patients. So in thinking about how to further develop the framework into a module, our team gained insight from Serena Thompson and James Bradley, who were able to provide us with a wealth of information regarding what topics would be important during transition. As a team, we also came across the Sickle Cell Disease Education Program for healthcare providers through SCAGO, which provides accredited learning modules on SCD for healthcare providers, in which we were able to connect with Karen Fleming, who is the education coordinator of these modules, to develop a module on sickle cell disease transition for healthcare providers. So after connecting with Karen, it was decided that module 9, as you can see on the left, was originally going to cover vaccinations. However, this content will be covered in another section. And so now there is a module for transition for young adults and adolescents with sickle cell disease, in which these are just the screenshots from the website. And moving forward, we are in the process of developing and finalizing the module with SCAGO. And we thank you for your time. We will take any questions that you may have now.
Amazing. Awesome. Thank you so much, this incredible team also, for such a comprehensive presentation today and enlightening us on this great work. So we're just going to start off a quick Q&A session. Just to pivot us off, I am just going to ask one question while others put stuff in the chat if possible. I know there is a poll that you have to do also. So I think it may have already popped up on the screen. So actually, if you can do that poll, and then I'll just save the question for 1 minute after. Do you guys see that on your end, all our attendees? Awesome. All right, if you guys can complete that poll. I have a question for you, Dr. Kofi. That was incredible what you showed us in terms of assessing the psychosocial status of these children as well as adults. And I see you mentioned a few scales that I'm also familiar with. The ED 5D, I think it was is it EQ or ED 5DY?
EQ 5D, yeah.
EQ, yes, 5DY, yes. And so, just wondering for a few of them in assessing the quality of life, some of these patients, like that scale I know starts at 8 to 15. Are there any specific scales that we have for children under that age? Because I'm just thinking of the younger pediatric population and being able to assess their level of, psychological distress and peace of mind.
Yeah, they are. But unfortunately, most of the scales for the younger children are targeted towards the parents or the caregivers.
Right.
Just because sometimes I think it's just about comprehension and so on. But there are some scales that can be used directly with the younger children as well. So it's just a whole range of stuff, but I just gave some examples. Yeah.
Oh yeah, no, that's great. That's great. And I did see from your table, you like pain, anxiety, depression, fatigue, neurocognitive, that I feel like all of that also stems into the quality of life.
Yes.
And so you showed that great table there. I assume it's factored into those scales also, right? Because I saw they're separate rows.
So usually when you look at quality of life, you try and break it down into some of those key areas. And so the domains that I chose are the ones that have been commonly reported as being issues around quality of life. But, you know, some of the Sickle specific ones actually are more extensive in terms of trying to cover some of the other social and also in some cases trying to get a sense of, you know, people's different ways in which they cope, which may not necessarily be captured you know, using the typical ones that we use as well.
Oh, that's great. Awesome. Thank you for that. We just have a few more seconds before we have to transition. So I don't know if there's any other questions. I don't see any in the Q&A. I guess the presenters were so exceptional. Just a quick question for our team. Anyone could take this. Have you guys thought of how AI can feed into your final product with these module creations, just assessing the common questions, just something to think about if you have a quick answer, or if this is something that you guys can just, you know, maybe follow up with us on. Anyone can.
I can try answering this. I think there's a lot more in terms of feasibility in the near future. Right now, AI is still up and coming, so there's a lot of factors there to be considered, especially with like patient ethics and things like that. Right now, the material we've created is very tailored towards the participants we had in our focus groups. So it'd be more so used for that type of population, and it's representing their needs specifically. Perhaps AI could be used to gather more voices or look through larger data sets. So maybe that's a potential.
Yeah, that's great. Thank you, guys. Well, I just want to thank all of our speakers, our guest speakers today. Thank you for an incredible job and for giving us such comprehensive, well thought out presentations today. I just want to thank everyone who's attended this session. Just to remind you, don't go away. There's a special plenary session, a follow-up with Ontario hospitals and quality care for sickle cell disease. There's still gaps to be addressed. That is starting at 1:35. So I just want to let you guys know, don't go away. Stay tuned for that session. And once again, thank you to every one of our attendees, our amazing speakers today. And we have lots more exciting stuff to come. So stay tuned. Thank you, everyone, and enjoy the next session and the rest of the summit.